Welcome. I'm with my guest today, Dr. Tom Schmicker, who's also my buddy from med school. It's good to see you.
Nice to see you. Thanks for having me, Avir.
I'm super psyched. Today, we're going to talk about peri-prosthetic joint infections and how
Yeah,
to figure out if you have one in the emergency department and what to do about it. So maybe we could
exactly.
just start by defining what is a peri-prosthetic joint infection.
Yeah. So, broadly, a periprosthetic joint infection is an infection around a joint that's been replaced. So that could be, I'm a total hip and total knee surgeon. So for me, it's around the total knee or the total hip, but it also holds true for shoulders, ankles, elbows.
Okay. So basically, the things we're talking about here apply to any prosthetic joint, no matter where it is.
Yes, essentially.
Well, let's start with what are the risk factors for someone to get a prosthetic joint infection?
Well, diabetics, people who inject drugs, people with inflammatory arthritis.
Okay. And it
Mhm.
spreads sort of the same way for us as a regular septic joint, where it can be hematogenous spread or direct
Sure.
inoculation.
Exactly, yeah. And a lot of infections occur at the time of surgery and then they're recognized later as well.
Okay, right. So they have that additional risk factor of, having had the joint penetrated in the OR that could lead to an infection down the road. Um,
Mhm.
okay, cool. So let's go through sort of the physical exam, comparing it to someone with a septic joint, right? Someone has a septic joint, we're familiar with that. It's going to be red, hot, very angry, warm to the touch, very tender. What's a prosthetic joint infection going to look like?
Yeah. Um, a patient with a periprosthetic joint infection can present much like someone who has a native joint infection. With a red hot, swollen, angry knee. And that's an easy diagnosis. And you'll have patients who present with a sinus tract. That's something that you never want to see. But again, that's an easy diagnosis, and that's a hard sign of periprosthetic joint infection. But on the other hand, you do have these indolent infections that don't necessarily jump out at you and scream infection. And you know, there's a very good portion of patients with PJIs who present just that way. That's why you need to have very high suspicion for it when someone with a replaced joint comes in complaining of pain.
So kind of they may just have like a traumatic joint pain. It may not be super warm. It may not be super tender type of thing.
Yeah, for sure. For example, when a patient comes to my office and they have a joint that's in there and they're complaining of pain, and that joint may have been there forever. If I'm considering doing a surgery for them, like a revision surgery, I'll always rule out infection before I do anything because an infection is, the most common reason for revision of a total joint.
Okay. So more subtle presentation, potentially a more subtle presentation than a regular septic joint. Um,
Absolutely.
so you have to be very suspicious. Okay. So then let's say, you have a patient, they have had a knee replacement years ago and they're complaining of knee pain. It's a little tender. What are you going to do next?
So physical exam, yeah. You take a peek at that knee. You know, if you see that it's red hot swollen, that's a slam dunk. You can get X-rays. Sometimes infection will be picked up on X-ray. Some of the things that you could see are, loosening of the implant, which looks like radiolucent lines surrounding the implant. Sometimes you can see like scalloping, endosteal scalloping that can sometimes give it away. But that would be a pretty severe case. A lot of the time, you're not going to see anything on the X-ray.
Okay. And it's possible that maybe would you see possibly a joint effusion just like in a septic joint too, or
Absolutely, yeah. You'll see an effusion a lot of the time, but not necessarily. Again, and a lot of different organisms will cause PJI, and some of these organisms are they cause pretty indolent infections that are hard to pick up and might not necessarily cause a big effusion.
Gotcha. Okay, so maybe you'll see something interesting on the X-ray, maybe you won't. So then what do you do?
So the next thing is lab work. Um, you know, uh, the most important thing to order are inflammatory markers, which is, in this case, it's ESR and the CRP. Most surgeons will also order a CBC or a BMP. In CBC, you're looking for an elevated white count. But I would argue that that's not as important as getting the ESR and CRP, for which, the MSIS, or the Musculoskeletal Infection Society, has defined thresholds for what constitutes, a total joint infection. So, it's difficult to diagnose infection for orthopedic surgeons. So we've come up with these scores, But the first step is the lab work. So you get the ESR and CRP. And if a patient who has had a total joint that was put in greater than 90 days ago, there's a threshold. And if their CRP is greater than 1 milligram per deciliter, then you would proceed with the next step in diagnosing an infection. ESR, if that's greater than 30, that's also another tip-off that you continue to start diagnosing infection. And the next step would be an aspiration of the joint.
Okay, so as long as the joint's greater than 90 days, it's been there for greater than 90 days, then a CRP greater than 1, ESR greater than 30, that's going to be like your suspicion's going up. If it's negative, are you done there?
So if it's negative, then you do not need to proceed with an aspiration. In the emergency room, at that point, you could kind of say, we're done with this patient. ESR and CRP is not high enough to aspirate.
Okay. What about if it's sooner than 90 days?
Yeah, so that's a good question. That's something that you'll see a lot. You'll see, patients, and it's really hard to tell what's going on because these patients will have post-operative pain, which really complicates the picture. So the thresholds are different. CRP in that case is 10. So much higher threshold for that. And ESR actually has no defined threshold in that period. So CRP is supposed to return to normal around 21 days after surgery, but that's different for every patient. But right at that time point, it's 10 milligrams per deciliter. Again, it's important because some hospitals measure CRP in milligrams per liter.
Okay, so 10 up to 90 days. I mean, probably someone comes into the ER within 90 days post-operatively. I would imagine we're going to consult the operative team just because they're so close to being post-op. We'll let them figure it out. But it's good to know that your CRP can be a little higher directly post-op from all the inflammatory changes from the surgery itself, I guess.
Yeah, of course. Yeah. Mm-hmm.
Okay. All right. So let's say we got this patient, they came in with the issue we described, tender atraumatic joint, X-ray didn't show anything, but we did labs and their ESR is like above 30. It's like 50. So now what do we do?
Mm-hmm. So you would go to an aspiration. You do the aspiration. You always send it for a cell count with diff, and you would also send it for a culture, and you can also get crystals and glucose and protein levels and things like that. That's more academic than that has no diagnostic value. But so now you send it to the lab, and you're looking for the number of white blood cells in the synovial fluid. And we have a threshold for that, which is 3,000. So if there's more than 3,000 white blood cells in the synovial fluid, that's another strike against this patient towards having a joint infection.
And that's interesting because, that's such a lower number than a regular septic joint.
Yeah. A regular septic joint, you're looking to diagnose an infection about 50,000. But yeah, for peri-prosthetic joint infection, it's much, much lower.
Okay, so 3,000. And that's that's like before 90 days, after 90 days, it doesn't matter.
So yeah, okay, good point. Yeah, so before 90 days, now you're looking at 10,000 white blood cells.
Okay.
It's got to be much higher. Yeah.
Okay. So 3,000 white cells, and you're going to culture that. Is there any other things that you might test or look at, like things that you would do in your field that aren't standard for our field?
Um, yeah, so I mean, there's some adjuncts that you can do that can help you diagnose. First, the diff in the white blood cell count. So if it's greater than 80% PMNs, that's another strike against the patient. That's pointing towards infection. I use leukocyte esterase, which has been shown to be a really good, specific, and sensitive test. So you just take a regular urine dipstick, you put a little bit of synovial fluid on that, and a plus plus result on the leukocyte esterase strip. That's another strike. And I keep saying strike because there's a rubric that we use. And if the patient has greater than 6 strikes against them, then that's you can be pretty sure that that joint is infected.
Gotcha. Okay. Anything else?
So there's some specialized things that not everyone uses that can be pretty expensive. So the most innovative, technologically advanced thing that people are doing now is they're doing, sequencing. They're looking for, genetic material of bacteria within the synovial fluid. And a lot of this stuff is actually coming out of Rothman. They have a pretty robust PJI research team there. There's another thing they're using alpha defensin, which is a protein that can be tested, and that is also extremely sensitive and specific. A lot of these things are, if you're not quite sure, you're on the fence, you don't have enough points against the patient for a PJI, you can turn to some of these things to try and help you make a diagnosis.
Okay. All right.
Yeah.
So let's go back to our patient, tender knee, X-ray normal, ESR high, and then we tap it, and there's greater than 3,000 whites. What do we do?
Yeah, so that's a very good question. So you're at you have a number of options. So if this patient has been having symptoms for a long time, and we'll say in this case, the patient's having symptoms for like 6 months. At this point, it's all about the biofilm. So as you remember from medical school, bacteria will exist in the joint in its planktonic state, and then it can agglutinate on the surface of the metal, which does really easily in comparison to native tissue. And it forms a biofilm with the protective glycocalyx. At this point, antibiotics can't get to it, can't penetrate it. So oral IV antibiotics are not going to do anything for this patient. So they need a surgery. All patients with a peri-prosthetic joint infection need a surgery. And this patient has had long-term symptoms. They've built up the biofilm. You're going to need to take all those components out. You're going to need to put in an antibiotic spacer. You're going to need to wait 6 weeks. You're going to need to have IV antibiotics that whole time. You need to take another set of inflammatory markers, make sure they're at least coming down, if not normalized. And then you take out the antibiotic spacer, and then you can put in your revision components. And that's the whole process for that patient. It's extremely involved, high mortality, has a higher mortality than a number of cancers. It can be pretty, PJI is devastating, I can tell you that much. But on the other hand, if the patient's been having symptoms maybe for 3 to 5 days, or if this patient is, acutely post-op, you can, make the assumption that there's no biofilm. So you can go in there, you can debride them, give them antibiotics, and retain the implants, and then close them up and cross your fingers and hope for the best. And that works, less than 100% of the time. It depends what organism you find in there. There's some extremely aggressive virulent organisms like MRSA that you're just not going to get rid of. That has a much lower chance of you getting rid of it with the implant retention procedure. So but that's another choice.
Gotcha. So none of these patients can really go home with antibiotics, and none of them really can just deal with IV antibiotics inpatient. Like they need a procedure.
Well, you do have some patients that are, extremely elderly, debilitated, that might not withstand or might not be good candidates for any procedure. In that case, you could do chronic suppression. But that's sort of, your last resort. But yeah, there are patients that you can do chronic suppression for. But I would argue, other than that, there's no room for giving a patient with suspected PJI oral IV antibiotics and sending them home, because that'll just muddy the picture for the orthopedic surgeon who's going to get that patient down the road.
Yeah, that makes sense. And all these things we talked about, we were talking about the knee in this case, but that applies to literally any joint that's been replaced.
Yeah, it used to be different between hips and knees. There are different thresholds, but over the years they found that it's the same, most accurate to use that 3,000 threshold mark. That's the MSIS 2018 criteria. I mean, if you read something else, that's the most commonly used, but you can read other sources which have different thresholds.
Great. Well, that's super clear. Anything we missed there?
In Europe, they do everything one stage, meaning that they skip the whole antibiotic spacer. They go and they do a radical debridement. They take out the MCL, the LCL, whatever left of the cruciate ligaments, and then they put in a hinge prosthesis. They think that's the best thing. And in the US, we use the antibiotic spacer. It's kind of geographic difference there.
Okay, interesting.
Yeah.
Cool. Thank you so much.
Yeah, my pleasure. Thanks for having me.